All right, so good afternoon, everyone. We are now in our part two of our discussion. So the part one, we have identified the different specific age group and how do we design a health education program for them based on the characteristics, based on the development of each of the age populations or different population based on their age. No? And at this point, we will be discussing how do we implement the plans that we have created. So number one here in my slide is assessment. So it's very important for you educators to be able to first analyze, assess the process or the teaching method or the conditions of your learners for you to be able to implement your health education plan, no? So you have to determine the learner's needs to know when and under what conditions the learner is most receptive to learning. So when you say learner's needs, because you cannot just go to your patients, to your nurses, no, to your clients, to your students, and teach them whatever you want to teach, no, or you just feel to teach something or a topic like this, but it is not beneficial to them because this is not their learning needs, no. Me as a training officer in this institution, what I do is I have a checklist. No, I have a checklist or I have a form where I distribute it in the stations, and I will allow or let my nurses enumerate the trainings that they need, no, based on their self-assessment. So let's say, for example, I would say, oh, I'm poor in catheter insertion, Foley catheter insertion. So they will place it there, training on or updates on catheter insertion or updates on computation of emergency drugs. So they will tend to itemize, enumerate it, and base it on priority. So number one being the highest priority, and the least or the next following items will be the least priority or the last priority. So that's how you assess what are really their learning needs. Unsa kung what do I need, no? Unsa kung kinahanglan kung sa Bisaya pa, no? And under what conditions the learner is most receptive to learning. In what condition are they really willing to learn? In what particular situation they are really ready to learn, no? So you have to consider, of course, if the patient is still sick, drowsy, having pain, of course you cannot tell your or implement your health education to a patient who is suffering from pain, or a staff who just came from night shift and then doesn't have enough sleep. So your education won't be effective. So identify the most appropriate timing, no, that your learners are ready. Your learners are now ready to accept the information that you're trying to impart to them, the best possible environment or condition that they are, no? So before a decision can be made about selecting the content to be taught or choosing the instructional methods and materials to be used to change learners' behavior, the educator must first decide what the learner is expected to accomplish. So what do we expect from them, no? So clients' needs are determined by identifying the gaps in the learner's knowledge, attitudes, or skills. Identification of needs is a prerequisite to formulating behavioral objectives that serve to guide subsequent planning, implementation, and evaluation of teaching and learning. So therefore, you have to identify the learning needs. That's a separate entity, and you have to identify needs, meaning what are the trainings that they want to know more about. If you say gap, the competency gap, you have to know what are the weaknesses of this staff on that particular procedure. So my next slide would show you an example of what I use in the institution. This is a checklist, no, very basic checklist. Let's say, for example, oxygen administration. So each of the individual staff, me as a trainer and nurse educator in the hospital, I will assess them if they really know how to administer oxygen, no? So following the guidelines, knowledge, and skills, there's still attitude in the next page of this form. I haven't placed it there, so I just put this an example, the knowledge and the skills contents, no? So knowledge, under knowledge, there are the following criterias or items, no? Be able to discuss the indications of oxygen therapy. So meaning you will ask your nurse, kindly discuss when do we put the patient on oxygen therapy. So what are the indications? So maybe the nurse would say having difficulty of breathing, pulse oximeter or the O2 saturation reading is below 95%, so and so on and so forth. Or if the patient is or on a what regulated drug that is respiratory depressant, no, or medication that would put them to sleep, no, that they need oxygen inhalation to support their what respiratory function. So if your nurse is able to answer that, then you can give number three, no, a point, 3 points, no, meaning knowledgeable. The needs improvement, then zero knowledge. So then you will check all of the rest of the items, and then you will then see if there's a gap, no. How much is the points? Which area does your nurse doesn't know about or has a zero knowledge? Then you focus on that. And that's where your program, health education program, will be based upon, no? So as you can see, oh my gosh, they don't know how to put the oxygen cannula to or to put a face mask cannula or face mask oxygen what is we call this the oxygen face mask device, no. So if your staff doesn't know how to put that to your patient, then that is something that you must be focusing on and try to align your program towards that, no, focusing on that item. So that's how you assess the gap, no, the gap for your program. Now then after that, you will then focus on your goals and objectives. So objectives, no, is very important. This is used to identify the intended outcomes of the education process. So you would know what is really your goal at the end of this activity. So my goal is for the nurses to know how to administer oxygen therapy to the patient. They would know the indication, they would know how to apply, to put, when to stop, when to increase, what's the level of auto inhalation based on the devices that you'll be using, and so on and so forth. No, that must be properly identified based on your specific goals and specific objectives, your broad goals rather, and your specific objectives. And then writing a behavioral objectives again has three main important characters. This has been mentioned already by, I think that was Ma'am Shai's presentation in the midterm weeks before, no. So performance, condition, and criterion. So we all know that performance, this describes the learner's expected or what we expect that the learner should perform, no. So if you say I expect my learner to perform CPR properly, no, cardiopulmonary resuscitation, so then you will assess if they're able to do it correctly, no. Condition, no? So this describes the testing condition or constraints under which the behavior will be observed or the performance is expected to occur. The scenario that you will be putting the patient on. So let's say, for example, I'll be saying, I'll give you a scenario wherein the patient is having seizure. So that is a condition wherein you will observe the skills of your staff, no? Okay, criterion, no, describes how well or with what accuracy. What is your criteria? Accuracy that the learner must be able to perform for the behavior to be considered passed, acceptable, high remarks, standard, or extraordinary, no, based on the quality. So that is what you call the criterion, the state of the level of performance. So you base that in three characteristics when you set your or writing your behavioral objectives. So now we will now evaluate. So after we have designed, implement, now it's time to evaluate. No? So evaluating a health education plan is defined as a systematic process that judges the worth or value of something, in this case, the teaching and the learning. So how is the teaching being done? Is it done effectively? So does the learner able to grasp the outcomes? We're able to achieve our goals at this point, no? So evaluation can provide evidence that what nurses do as educators makes a value added difference in the care they provide. So steps in conducting an evaluation. First, determine the focus of the evaluation. So we would know which part or what are we evaluating? What is really our focus? Is it on the performance of our staff? Is it the test results? No? Design an evaluation for you to be able to effectively measure or gauge their understanding. Conduct the evaluation. So you can conduct your evaluation. It depends on the method. It could be verbal, written, interview. No, it depends. No, if you have a tool. Determine methods to analyze and interpret the data collected. No. So you have the basic statistics now, gathering data like what is the average or what is the mean score of the students. You call the average. You collect the data that you will be needing, or comparing data also. So you'll be needing somebody who's knowledgeable in using your SPSS, if that is how tedious the process would be. No, reports result and a summary of the findings from the data collected. So you have to be able to share or made aware the people who's involved in creating your health education program, so that they would know how to improve. No, because that's a very important thing. How do we improve for us to address the things that was not met, no, the objectives that were not met? So how do we address that? Then use the evaluation tool, or use the evaluation tool for quality improvement, for solving any concerns and issues. No, so that's the beauty of evaluating a particular activity. So evidence-based, no, evidence-based practice, these are or defined as the consensuous use of current best evidence in making decision about patient care. So before we implement any policy in an institution, before we draft a protocol, no, or a procedure, you have to base it on evidence-based practice. So I think we've heard about this concept, no? So when you say evidence-based practice, you tend to we tend to apply or translate research findings in our daily patient care practices and clinical decision making. So whatever the findings of researchers made, we tend to collate, no, those researches or articles or journals that we can gather about this particular topic, and then we try to assess the results of their research, and we then apply it, because this is where you would base if your practices is truly following the standards. No, so let's say, for example, doing let's say injecting intramuscular vaccine. No, do we have to aspirate the blood or not? So let's say, for example, that very basic question. So where will you base your policy or protocol about that? So you can actually research studies who conducted researches, no, about that topic in IM insertions. I actually have read one article. So according to that article, there's no need for you to aspirate, because there's less tendency that you'll be able to hit a vein. And the longer the needle will be placed on the arm of the patient would cause what? Uncomfortability to the patient, or more pain to the patient. So that's why you have to do it as quick as possible. So there's no need for you to aspirate. No, so it's still therefore, if there are institutions who still does that, meaning they are not looking into what is the updates, what are the evidence-based practices that are really based on clinical findings. No, so you have to base your practices towards that, because sometimes in an institution you tend to follow what you have done for the past 10 years, and that might not be safe for the patient anymore. So if you do your evidence-based practice, you follow the 3 items. No, the clinical expertise, meaning there are people in your working environment that are really expert on that particular topic or concept. Then you tend to ask them, no, what are their experiences, what are their opinion. Best research evidence, we conduct meta analysis. So when you say meta analysis, it's the highest form of acquiring knowledge. Meta analysis meaning you gather all the possible studies and you try to sum everything up, and then you try to analyze all of their findings. And then patient values and preferences. Of course, we have to hear the feedback of the patient. Whatever are their opinion, that's always valid. And that's how we can satisfy them. And that's where we will improve also our practices. That's why this is very important, no? Having an evidence-based practice basis for all our procedures, no? Very, very relevant, important. So one of the evaluation models that we have, or the two common models, we have the formative and summative. So evaluation can be classified into different types or categories. The most common type of evaluation identified includes some combination of process known as formative evaluation and outcome, also known as summative evaluation. So let's learn each one of the models. So when you say formative evaluation, the purpose of process evaluation or formative evaluation is to make necessary adjustment to an educational activity as soon as they are identified. So it's during your discussion, such as changes in personnel, materials, facilities, teaching methods, learning objectives, or even the educator's own attitude. So that is the moment that you are conducting your education, you can actually adjust it as soon as you identify a particular concern or problem in the learning process. So formative evaluation or process evaluation is a component of the ongoing education cycle of assessing, planning, implementation. Process evaluation helps the nurse anticipate and prevent problems before they occur or identify problems as they arise. So what are the examples of formative evaluation? So class discussions can be a form of formative evaluation, that is right after you have discussed or during your discussion, you tend to ask questions, throw questions, ask participation from your audience. So that's when you evaluate and assess if they have learned something, no? Clicker questions, meaning very quick questions, right there and then, no, you can ask questions to your staff. Weekly quizzes. Now, weekly quizzes can also be formative evaluation, so that you can address whatever identified problems in the learning or in the education program that you created. Then you can address it immediately. Is it because of the educator's performance, or how the educator delivers the lessons, no? So maybe you can take a look at that. When you say summative evaluation, so the purpose of outcome evaluation or summative evaluation is to determine the effects of teaching efforts, no? So outcome summative evaluation measures the changes that result from teaching and learning process. So this type of evaluation summarizes what happened based on education intervention. So guiding questions in outcome evaluation include the following: was teaching appropriate? Did the learner or did the individual learn? Were behavioral objectives met? Did the patient who learned a skill before discharge use that skill correctly once at home? Did the student nurse who acquired a new skill in laboratory setting or staff nurse who learned a new skill in continuing education session demonstrate the ability to independently perform that skill accurately in practice? So meaning, if you have this set of questions, the goal of the summative assessment or evaluation is to evaluate the student's learning at the end of an instructional unit, no, by comparing it against a standard, against your criterion, no? So what are the example of a summative evaluation? Let's say you want your students to create a portfolio, no? So you can ask your students to create a portfolio, a creative portfolio wherein it will reflect the learnings that they've had, no? Or a final project, or an end test chapter, so an end chapter test. So the moment that you finish a particular chapter, you can give a long quiz for them, and that is a summative evaluation at the end of the whole instructional process or unit, no? So as you can see in the picture, the ones that I post or pasted. So if you say formative, no, while you are cooking, you try to check, no, the before you end the cooking, you have to try to test and check. So according to the picture, it needs a little salt. So you evaluate na during the process, you tend to address immediately the concern on that moment. So then you add salt. And then the summative assessment is after cooking, your clients will then taste the food. So their evaluation is it tastes great. So meaning at the end of the cooking process. So when you say formative, when the chef tastes the soup, summative, when the guests taste the soup. So formative meaning if the teacher would then what? Assess the students. Summative could be the result or the outcome. So meaning it would be the stakeholders. Let's say, for example, in the hospital, it will be our patients who will be now assessing our nurses if they're able to perform well. Because that's the overall outcome of a training program. For me, I'm a training officer. So at the end of 2-month period, my summative evaluation would be the feedback. The feedback of our guests, their evaluation. So formative helps students to learn and practice when throughout the course. Why? Identify gaps and improve learning. And how do we do that? Via approaches that support specific student needs. Summative, assess student performance when at the end of the instructional period. Why? For us to be able to collect evidence of student knowledge, skills, or their competencies or proficiencies. How? Via exit learning products or a cumulative assessment tools methods. Now, our next topic would be the nursing documentation. This is very interesting. So after we have designed our health education plan, we implement, then we evaluate. Now we have to discuss how do we really properly document things. So why write it down? So always remember, if it's not documented, we always will assume and think that it has never been done. So the pen is more accurate than our memory. Do you agree? I totally agree. Most of the people have very short span or short memory span. So we have to write everything, take down notes. Because after a day or two, you will really forget the things that your professors are teaching you. So you have to recall everything. So lucky for you, you have the pre-recorded video. You can tend to review it back. So documentation basis. So documentation is factual information about the patients and charts. It contains information regarding the needs and conditions of the patient, care provided to the patient by the nursing staff. So this is where we document our nursing care, our FDAR, nurses notes. This is where we put our goals, our data, the focus, that's the after the focus, data, actions, and response. It occurs on an ongoing basis. Again, it's a cycle. First-hand record of observations made by the nursing staff. So that's where we indicate our observations. That's for legal purposes. So what is documentation? So documenting the basic includes the following. It should be chronological order. It must be by date and time. Because if you won't follow this, you will be questionable to any legal issues. So let's say you are writing your nurse's notes. Is it okay that your 10 a.m. is above the 7 a.m.? So that is questionable, right? So that must be in a chronological order. Client history, your assessment on your client. Interventions, the medical side, social side. What are the interventions that the hospital, the staff has been done to the patient? Observations, is it objective, subjective? So we all know that objective cues are those that are measurable, can be seen, can be measured. Subjectives are those data that has been verbalized by the patient. Client outcomes, what are our goals? It's the same with the learning outcomes that we have. Client and family response. Authorship, your full name, credentials, and signature. Those are very important. That's why here in the hospital, I require the TRODAT. no? Because it's really time consuming if you will put all your name and then your license number. So I require all of my nurses to use the TRODAT so that you, and then sometimes the penmanship cannot be read, no? Very hard to read. So you have to use na lang your TRODAT so that it will be easy for you to finish, no? It's fast for you to finish. And it's easy to trace who was the name of the staff who cared for the patient. So we have to practice the 4 C's when documenting. This will ensure that you're documenting well, no? Very clear, concise, no? Specific, correct, and complete. Everything must be in this frame, no? Must be clear, concise, correct, and complete. Always remember that. So a good test to evaluate whether your documentation is satisfactory is to ask the following question. If another nurse had to step in and take over care for this patient, does the chart provide sufficient information for the seamless delivery of safe, competent, and ethical care? So if I will be the ones who will be caring for the patient after this shift, no, was the care or interventions done appropriately based on safety, competency, and ethical care? Okay, is the answer yes? So that is when you read the documents, wow, the nurse was able to what? Perform the following intervention. Yeah, of course they were able to do the appropriate interventions. But if you just written in your nurse's notes, very vague notes, there's no direction, there's no objective, then probably the answer is no there, right? So that is not a good documentation. So why do we document? This is to ensure that services that we're paid for, that the patient, no, resident or patient, are delivered towards them. No, provide a picture of the patient or resident's condition, detail how a patient or resident is responding to treatment. So that is where we put everything, no, the responses of our patients or residents, determine the amount of Medicare or reimbursement a facility receives for care. Of course, we need the PhilHealth reimbursement, right? Because it's hard for hospitals to function without the PhilHealth reimbursement. And PhilHealth has a very strict requirement in terms of completing the patient's chart. No, it is a legal record of care that can be used in a court of law. Again, any inconsistencies in the chart documentation will pose your institution and you yourself to any legal suits. No, so be very careful. Documentation influences the decision subsequent caregivers will make regarding a client's condition. So that is where influences in the decisions, no, of our caregiver will be the basis. No? So the purpose of your documentation to have a clear, complete, accurate health records serve many purposes for the rest of the stakeholders, patients, family, nurses, and other healthcare providers. The data for documentations allows for communication and continuity of care because you endorse it to the next staff. And the doctors will also be reading your notes. So that's where we communicate to other healthcare professionals. Coordination of services, that's what I mentioned. Again, there will be what? Dietary services, there will be PT, physical therapy services. So they will be reading the charts and they will be getting relevant information from your end as a nurse. No? Quality improvement, risk management chart is also the basis, establishes professional accountability, legal reasons, finding and resource management, and expanding the science of nursing. So for evidence practices, researches, we utilize our documentation. No? So what should be in our document? So nursing documentation should contain the following: all aspects of the nursing process. So the assessment, the diagnosis, no, the plan of care. So again, there, the plan of care, admission, transfer, transport, and discharge information, those must be reflected there. The patient's education or resident education, medication administration reflected on the medication sheet, collaboration with other healthcare providers. Again, in one patient, there could be lots of doctors because they collaborate with each other. Like if a patient needs consultation with pulmonologist and I need also a consultation with a cardiologist, that they will be working hand in hand. No? So that must be clearly documented in the chart. So I have here a sample chart in the hospital. So this is what we use. So this is a blank chart which can be found in the admitting section. So this is where all of the data of the patient will be reflected. So these are blank pages. No? During my training program for nurses, I do teach this also. I orient them of the parts of the charts. Okay, so this is very, very important. Okay, standard for documentation, we've made mention already. Clear, accurate, legible. So your hand penmanship or writing must be very clear. Timely, factual, documented by staff who performs the care, and must be organized, must be in a chronological order. Again, if you have errors, what will you do? You just, can you put a snow peak or white erasure to that? That's not allowed in documenting. If there's an error, just put a straight line in the middle of your word and then sign. You put error and then you sign. Okay. Rules in documenting: document using black or blue pen. This may also be facility driven, so depends on the institutional policy. So you may use black or blue depending on the protocol. Ensure that there are no skipped lines in between sentences, as this allows for possibility of additions to be made to the chart at a later time. Meaning, if you have a very long gap, no, so you have an entry here na ay gap, entry na po, so there's a space. So avoid big skipped spaces or one single space, because anyone could just add something, no, that would then change the whole picture of the interventions being done to the patient. Document only what you have done to the care for the treatment of the patient. You should never document a task or treatment that you did not perform. That's not allowed. Do not make changes to the chart unless you are correcting your own work. Do not edit others' work. When making corrections, be sure to line through the word, that's what I told you, with one line and your initials or signature. Do not use whiteout or corrective state. That's not allowed. Use only facility-approved abbreviation and terminologies. What do we mean by, it's supposedly internationally approved abbreviations? So there's lots of abbreviations that nurses do create in the area because they just want to write it so that they won't, for example, a very lengthy term, so long term, so they tend to have their own abbreviation. You can use that in your scratch paper, but never in the chart. No, never in the chart, because we have the ticklers. The nurses has ticklers, kana murag scratch paper, where you can just write anything, reminders during the day. So you can put your abbreviations there, but you cannot put that abbreviation in the chart, because that's a legal document. The only abbreviation that you can put in the chart is the internationally approved abbreviation. What's an example of that? Let's say, for example, AC meals, PACY meals, NPO. Those are the international approved abbreviations. So what are not internationally approved abbreviations? My nurses tend to use, let's say, for example, SCP. What is SCP? They just formulated that to specimen cup provided. So they created an abbreviation that is not approved. So you do not use that, or do not put that in your actual document. You can just write that in your scratch paper or your tickler. Okay? Lines through any unused lines to decrease the chances of additional. So if ever there's a space, no, there's a line that's being skipped, you can put a line through it so that nobody can add anything, add any items there, okay, to avoid any additions. Late entries in documentation. The definition of a late entry should be determined by the hospital or institution. What do you mean by a late entry? Documentation should occur as soon as possible, no, as soon as after the event has occurred. So you cannot bring the chart at home to make assignments. No, that's not allowed. Late entries or corrections incorporating omitted information in a health record should be made on a voluntary basis only when a nurse can accurately recall the event or care provided. No? So late entries must be clearly identified and should be individually dated. They should They should reference the actual date recorded as well as the time when the care or event occurred and must be signed by the nurse involved. And the late entries must be entered on a chart on the same shift that the care was provided, okay, before you go home, and must be in a chronological order. So good documentation versus poor documentation. Good documentation is clear, concise, and accurate. No, poor documentation leaves the record open to questions with no clear direction to follow. So if there will be patients complain and you don't have a very good documentation, you will be answerable for that. Be very careful. Common mistakes: failing to record patient's health or resident health or drug information, failed to sign the medication sheet that you already gave the drug, failure to record nursing actions, failure to record medications that has been given, that's what I said, recording on the wrong chart, oh my god, that's the wrong patient that you recorded in the other patient, that's a very big no-no. Failing to document a discontinued medication. So if that medication should not be given and you fail to discontinue that medication and the medication has been given all throughout the whole 8-hour shift, then that's a very big incident, no? Failing to record drug reaction or changes in the patient's condition, transcribing orders improperly, or transcribing improper orders. So that is a very big mistake also. Writing illegibly or incomplete records. So we have to avoid those. Ways to improve our documentation: be extra careful when you think you are too busy. So I said we have a tickler, scratch paper. You can still put all the things that you want to finalize in your chart. No, critical values should be recorded to the doctor within 30 minutes of verification. What are critical values? Let's say, for example, a laboratory result, and let's say, for example, the normal platelet count is 250,000 to above, and you have 30,000 of your platelet. So meaning that's a very critical value. You have to inform your doctor 30 minutes after verification, meaning you have to call the laboratory if that is really the real result before you call the doctor, so that there will be immediate intervention that will be done. If you chart by exception, know what the defined limits are, as charting is this instance is reporting abnormal findings. No, allergy should be highlighted. Here in the hospital, I do have ID bands for patients has special needs. No, charting patterns, including flow sheets, will be reviewed. Consult the policy and procedure for acceptable abbreviation. That's what I discussed earlier. Evaluate any new onset of pain. We have the electronic medical records, that's EMR, that is using digital, no? Because we want to avoid paper, because the more you write, the more mistake, and that will also take much of our time, no? Because we want to care more to the patient. So why kept on writing and writing? So that's why there's a paradigm shift now from writing to having it in the computer, no, having it in the system, no. So this is an electronic medical record, digital version of the traditional paper-based medical record for an individual. But then again, there's still the weakness of having this type of method. If ever there will be virus or the system will back down, you have to what? Reset, restart, and that will stop the whole process. So that's when you go back to paper-based. Now, everything is not, even the technology is not perfect. No, so there's still weaknesses that we have to consider as well. So the advantages of EMR: there's an easy access for physician to the patient's information, such as diagnosis, allergies, labs, and medication, that must be integrated in the system. So meaning if I type in the patient's name, I can see all. So meaning integrated, the laboratory, the medications, everything must be there. Access to new and past test results, meaning my previous hospitalization, I can access it. Computerized provider order entry, computerized decision support system, secure electronic communication among provider and patient access to health records, no, computerized administration process such as scheduling system, standardized based electronic data storage and reporting for patient safety and disease, for data surveillance, meaning for you to get data immediately, not doing it by manual, but you can extract the data out from the system. That's how valuable if you have EMR. Disadvantage, drop-down menus do not allow for any other options. Let's say, for example, what should be the diet of the patient? So in the drop-down menu, you only have what? Diet as tolerated, low salt, low fat, low protein. For example, kana lang tulo, the only three. Then you don't have any, then the patient's diet is what? Um, Low carbohydrates, diabetic diet, no dark colored foods, for example, that there's no other option. So that was one of the weakness. If no new information has surfaced, it is easy to be tempted not to record anything. All it takes is the click of a mouse on a wrong choice. So kung sa'yo put, if you placed a wrong error, if you clicked a wrong item, then that will lead to another error. Digital entries are not as robust as personal handwritten entries to trigger clear memory of events. No? Then the next is we have the informed consent. So informed consent is very important because this is where we primarily protect the patient's rights and assist in guiding ethical healthcare practice. So consent must be granted by the patient or legal guardian before a patient undergoes a procedure. So anything, no, admission consent, before they will be admitted in the hospital, the patient must be able to sign an admission consent before they submit themselves to any particular procedure. There must be a consent from them. No? So informed consent has three purposes: legal, ethical, and administrative, which can overlap. No? So the process should involve the physician providing. So who will facilitate the informed consent, the acquiring of the informed consent? So the process should involve the physician providing the patient with information on the diagnosis, procedure, or treatment, no? And then the risk and benefit of the procedure. So the doctor must be able to clearly explain what are the risks and benefit of a procedure. Then our role as a nurse is to ensure this information was provided and that the patient understands what has been communicated by the doctor. So consent is completed by using a specific consent form, but the process should be well documented in all areas, and the patient will then sign legibly his or her name. And then, but if the patient cannot sign legibly, then a thumb mark can be done. Or if the patient is um, incapacitated, meaning the patient cannot think, cannot move, or GCS3, meaning comatose patient, or patient is a baby, no. So the mother, the parent, the guardian can sign the waiver or the consent, and so on and so forth. So according to Hall and Menendez, 2012, they have listed several factors that affect obtaining also the informed consent. Patient comprehension. So does the patient able to understand? Can they understand English in the informed consent, or do you have Bisaya translation on the that form? No, readiness to learn. Locus of control, patient age, prior education, reading level, as I've said, no, cognitive function and anxiety, patient use of disclosed information. So the amount of detail the patient wants to know about a procedure can vary. No, patient autonomy, decision making can be made independently in collaboration with others. No, demands on providers, time can influence the ability to adequately complete the process. So give enough time for the patient to think about it, no? Because they are the ones who will be taking the risks. Physicians meeting minimum demands. The criteria must be met for completely informed decision making. And these are my following references. And thank you so much for listening. Have a great day, everyone.